This video is about femoroacetabular impingement and labral tears within the hip. First and foremost, I think the most important thing is to understand when we talk about pain coming from the hip, and when I say the hip, I mean the ball and socket joint itself, and whether that be from arthritis or in this instance a labral tear, where a patient normally feels that is within the groin, usually. Typically, when pain is coming more from the outside of the hip or maybe into the buttock, there's usually another source that's causing that pain, as opposed to an issue within the hip joint itself and an issue within the labrum. So typically when patients come into my office with this issue, they're describing growing pain, and it's made worse with hip flexion and rotation. It's also made worse with long driving, sitting with the hip in a flex position, and then sports specific. We can see it in all kinds of sports and in different positions, different sports, but certainly in sports that require deep squatting. So the workup for femoroacetabular impingement and labral tears certainly starts with the history, as we just discussed, and so the next step will be getting an x-ray. And in my office I typically get three different views. The first is just an AP pelvis, which is a straight on view, and then we will get a lateral of the hip, and then a slightly rotated x-ray of the hip. And what this allows us to see is, number one, is there any arthritis in the hip? Arthritis is a contraindication for undergoing a hip arthroscopy and labral repair. So anybody with arthritis will go down that non-operative treatment, and I have another video dedicated to hip arthritis that describes that more. The next thing that we carefully look at in the x-ray is the depth of the hip socket. So in femoroacetabular impingement and labral tearing, you can get issues from having a hip socket that's too deep and you have over coverage of the acetabulum, meaning that it covers the ball too much and then causes impingement. And then you can also have more of an instability of the hip, or a micro instability of the hip, which causes labral tears. And in that instance, we refer to that as a dysplasia, which means that the hip socket, instead of being overcovered, is actually undercovered, and it allows the ball of your hip to slip out, and because of this instability in the hip joint, that can lead to labral tears. So they're actually two pretty much opposite causes, which end up with the same symptoms of growing pain and the same result of a labral tear, but clearly there's different treatment options based on that, and we can tell that all from the x-ray. The other major thing that we glean from the x-ray is the presence of a cam bump or a cam deformity, and what that refers to is a overgrowth of bone on the hip. And so your hip is normally a ball, and then there's a nice rounded surface going down, and some people will develop what we call a cam bump, and so instead of this nice smooth surface, it'll bump up like that. And what that does is, as your hip flexes, it can further impinge on the labrum and kind of exacerbate tearing, and that has consequences in terms of if we end up doing surgery down the road. So those are the main things that we can glean from an x-ray, and then probably the last thing that we can really glean is we can usually see the lower aspect of your lumbar spine in the x-ray. So if you have any degenerative changes in your lumbar spine, we can usually glean this just from the pelvis x-ray, and that can give us some insight into additional factors that may be causing some pain. The next study that we often obtain when we're concerned about possible labral tear would be an MRI, and what that allows us to do is to see the soft tissues of the hip and specifically see the labrum. It also helps us to look at the cartilage within the hip and to make sure that even though it doesn't look like you have arthritis on the x-ray, the MRI gives us a three-dimensional look of the hip to make sure that there's no spots of arthritis that we maybe missed on x-ray. Sometimes we give the MRI with contrast, meaning we inject some dye into the hip, and sometimes we do it without contrast, and that's surgeon dependent. What's interesting with labral tears is that oftentimes I have patients come into my office that have already had an MRI, and the MRI shows a labral tear, and that's why they're in my office. So they present to my office saying, hey, I have a labral tear and I heard you fix these, so let's get it fixed. And that's actually a very common occurrence. And what I have to do in all these instances is take a step back and kind of explain that a labral tear is very different from other types of tears that we see in sports medicine, and probably most famously, and that all patients are familiar with, is an ACL tear. So in any athlete, yes, if you have an MRI that shows an ACL tear, if you're an active athlete, you almost always need surgery on that and need it fixed. But a labral tear is very different. So we don't know exactly, but we estimate that probably 30 to 40% of asymptomatic people walking around out there over the age of 35, probably if we were just to MRI their hip, it would show a labral tear, yet none of those patients or none of those people are symptomatic and showing up in my office. So the point of that is that just because you have a labral tear does not mean you need surgery, and that there is a very specific and regimented non-operative management that all patients must go through to see if they could be one of those patients that could improve and be one of those patients that has a labral tear on MRI but is not necessarily symptomatic. And so in terms of non-operative management, every patient that comes through my office that we diagnose with femoroacetabular impingement and a labral tear from the MRI will undergo a intra-articular steroid injection. And what that means is an injection that goes into the hip joint itself. And the way I do that in my office is with ultrasound. To get into the hip accurately, you need to use some type of imaging to aid you. And so in my office, I use an ultrasound. It's quick and easy. There are some physicians that prefer using x-ray, but nonetheless, you do have to use one of those two imaging modalities to accurately get into the hip joint. And so the point of the injection is twofold. So most patients ask me, well, this steroid injection isn't going to heal the labrum. Why should we do this? And that is true, that the steroid will not go in there and heal the labrum. But what it will tell us is, number one, I use it diagnostically, and what I mean by that is, not only is there steroid in the injection, but I have ropivacaine, which is a numbing agent in the injection. And so immediately in my office, usually within a minute or two, patients can tell if they have a significant difference, and again, that's the ropivacaine acting, not necessarily the steroid. So the first reason I use for this is diagnostic, and so I like for any patient that we're maybe considering a surgery in the future should have a considerable improvement, usually in my office, and then definitely a day or two later, once the steroid sets in, they should notice significant improvement in their symptoms, even if it's only temporary. The other purpose of the injection is it is a possible treatment. So while it doesn't repair the labral tear, what it can do is make you asymptomatic long enough to then work on physical therapy and strengthening to hopefully make you asymptomatic going forward, and for all intents and purposes, cure you of this problem. And so everybody who comes into my office will get the intra-articular steroid injection, and then I'll get them started in a intense physical therapy regimen for the next 6 weeks. And usually what that physical therapy is focusing on is strengthening around the lower extremities, to include quads, hamstrings, but most importantly, I think, is your glute medius and minimus, which are two of your glute muscles, which are underneath the big gluteus maximus and attach on the outside of your hip, and have been shown to be very important for hip stabilization. So I test that in the office with a one-legged squat. And so when you perform a one-legged squat, you're using a lot of muscles, but specifically you're using that glute medius and minimus quite a bit. So typically, when patients are very undercompensated in that area, they can't come close to performing a one-legged squat even using assistance. And then also with this is focusing on core strengthening. So the core does help alleviate some stresses on the hip. And then in general, flexibility. I think flexibility helps take some pressure off the hip, and usually by getting into physical therapy and doing some home exercises on your own, working on all these muscle groups. Sometimes patients resolve all their symptoms without needing any surgical treatment option, which I think is the best case scenario for patients. And this isn't a scientific statement. This is just, I think, what I've noticed in my practice is it tends to be about half the patients that come to me with MRI showing a labral tear and history and exam consistent with femoroacetabular impingement and labral tearing. I'd say about half of them get better with an intra-articular steroid injection and therapy. And that's just what I tend to notice. And then the other half we end up going down the surgical route. Again, that's not a scientific statement based on journal studies, and that's just from what I see in my own experience. So I typically see patients back after 6 weeks from the intra-articular injection and starting therapy and anti-inflammatory medication, and we kind of discuss how they feel. And essentially there's 3 options. And so number 1 is the patient says, I got no relief from the injection, and the therapy didn't help. None of this helped at all, and I'm still having the pain. That option always makes me step back a little bit and wonder, is this pain they're experiencing truly coming from the labral tear? You really should get some relief, even if it's only for a week or 2, from the injection and from the therapy, if your problem is truly coming from the labrum. And so when patients tell me they got no relief, it makes me step back a little bit and start to think about some other things that could be causing their hip pain. The next type of patient is the patient that says, hey, I felt awesome for 3 weeks or 4 weeks, and then now the pain's starting to come back, and maybe it's not back to where it was when they first met me, but it doesn't feel right anymore. In that instance, I think that's very, very helpful information to have, that they improved a lot. And again, I think that helps, cement in the patient's mind and in my mind that we know the exact source of their problem, that it's all coming from the hip, it's all coming from the labrum, and in theory, if we were to do a surgery in the future, it would probably have a good chance of resolving their problems. So with that patient, I typically offer them a repeat injection and continued therapy to see if they can continue to improve. In some patients, we could discuss surgery at that time point too, and it all kind of depends on what the patient's timeline is and what their, exactly how bad their symptoms are, and there's a lot that goes into that talk. The last type of patient, which is I think the best, is when they tell me that they got maybe 100% relief or close to it, and it's still working up to that point. And then obviously at that point we just continue with the therapy, continue doing what they're doing, don't change anything, and see if they can just have essentially resolved all their symptoms just with the therapy and the injection. Again, if it flares up on them in several more weeks, we could always repeat the injection, or again start to have the discussion about surgery. So when we decide that a patient needs a hip scope for labral repair, I almost always I order one more imaging study, and what that study is it's a 3-dimensional scan of the femur and acetabulum. And there's a specific company I use that analyzes that 3-dimensional scan and prints off a lot of useful information for me during surgery, and most specifically what it does is it assesses the exact amount of overgrowth or cam bump that's on the femur to allow me to really plan my cam resection, or my resection of that little bump during surgery very accurately. It also gives us a lot of measurements of the hip in terms of the rotation of the hip and how much over coverage of the hip socket there is, or under coverage of the hip socket. And so it allows us to really help with the planning for our surgery. So almost every patient that we decide for surgery will get that study. And so recently, some of the companies have developed what we call a postless traction bed, and so you're able to pull traction and get the required distraction of the hip joint, but you're not pulling against a post. And so what's nice about this is this completely eliminates that complication of the perineal nerve palsy. When we go into the hip joint itself, we first go through the capsule and open up the hip capsule to allow us to do work. We then typically shave down some of the acetabulum required to see the area between the labrum and where it attaches to the acetabulum, and sometimes we shave down a little extra if there is some overhanging acetabulum, and again that's based on the preoperative imaging. After we do this, we decide whether we want to repair or reconstruct the labrum, and what repairing means is that we just place some stitches through the labrum and into some anchors that go into the acetabulum. Usually this is at least three or four anchors, sometimes can be up to 7 or 8 anchors. If the labral tissue is very degenerative or very beat up, or we just deem it irreparable, the option at that point is to perform what we call a labral reconstruction. And there's different ways to do this depending on the surgeon. The way I typically do this is I use a cadaver tensor fasciolata, which is a tendon from a cadaver that comes in a sheet, and you can roll it to match the shape of the labrum, and then you make it the correct length based on your measurements inside the hip. And then you fasten that to the acetabulum with anchors and stitches, and what that does is that then grows into the body and becomes a new labrum for the patient, and that's termed a labral reconstruction. Regardless of whether we do a labral reconstruction or labral repair, the outcomes are typically the same for the patient, and it doesn't affect the rehab at all. So post-operatively, I place patients into a hip brace, which limits the amount of extension that the hip can have, and so this allows for range of motion from 30 degrees to 90 degrees of hip flexion. And what this does is it protects the capsular repair that we do at the end of the surgery. So full hip extension puts a lot of stress on that repair, so I limit that for 3 weeks. I also have patients stay 50% weight bearing for the first 3 weeks, and that's just to allow some of the swelling to come down, some of the healing to take place, and again, just to protect a lot of the repair that we did. I see patients in 5 to 7 days after surgery and make sure that things are going well, and then I see patients again at 3 weeks post-op when we allow them to take off the brace at that time point and then begin weight bearing more. I have patients begin stationary bike from day one. So I get patients in with therapy post-op day one, if possible, and start out with a stationary bike 10 to 15 minutes every day and on zero resistance. And that's shown to really help post-operative adhesions and help with the motion at the hip going forward. Again, I don't want patients to have full extension, so during that time period I have them put the seat down a little bit lower to keep the hip a little bit flexed. In general, after 3 weeks, you start weight bearing. I expect patients to be walking without a limp by 6 weeks post-op. all the while you're working with therapy, working on strengthening of your glutes, strengthening around the hip, strengthening of the core. And I allow patients to start light jogging at 3 months post-op. And depending on how you're doing with therapy, you can start faster jogging and up to sprinting around 5 months post-op. And it's about that same time period that we allow patients to start working on some change of direction or shuttle drills. In general, return to practice of sport is usually around 6 months post-op. And again, that's going to be light practice. That's not full game. And everything is tailored specifically to the patient and how you're doing with your recovery. At 5 to 6 months, when you return to sport, slowly you build up to faster and faster, closer to game speed. And my goal with this surgery is probably return to competitive sport and competitive play and games at about 9 months post-operative. There's been a lot of studies done on very high-level athletes. One of the most recent ones specifically was on NBA players, and this was one of the leading hip surgeons in the world, Mark Philippon, and his group up in Vail, and they did a study on about 15 NBA players who had labral repair arthroscopically, and their average return to play to the NBA in competitive games was about 8.5 months. So typically what I tell patients is that the goal is about 9 months to return to play. So it's not too, it's pretty similar to like an ACL reconstruction timeline. And so I go over this recovery in detail with my patients because I think it's very important to know that this is a long recovery that requires a lot of rehab, and this is not a quick fix, and this is not a quick return to play. But patients who we operate on for the right reasons and do a good surgery and have a really good work hard with their rehab tend to do very well with this. The last thing in terms of medicine after surgery, I place patients on naproxen, 500 milligrams once a day for 21 days. And naproxen is the generic form of Aleve, and that is to help prevent what we call heterotopic ossification, and that is what heterotopic ossification refers to, some extra bone growth around the hip. So just from going in through the capsule and doing a bunch of work around the hip, sometimes you can stimulate the body to form a little extra bone, which usually deposits around the hip capsule, and most of the time doesn't have any consequences. In very rare instances, it can cause some stiffness in the hip. What studies have shown is that by taking the naproxen or Aleve, 500 milligrams daily for 21 days after, it pretty much eliminates that complication of surgery. So every patient will be on the naproxen after surgery. I also have patients take aspirin 325 milligrams daily, and that's to help lower the risk of blood clots. And so very, very low risk of blood clots for this procedure, but any procedure you do where patient isn't doing their normal activities and is not stressing the body like they normally do, your blood pools a little bit and you have an increased risk of blood clots. So the 325 milligram aspirin does help to minimize that risk. I will send patients out with 20 pills of narcotic, and most patients don't even use all those pills. I will allow for one refill over the post-operative recovery, but most of my patients don't require the refill. Again, patients can also take some Tylenol in addition to help with pain control.